I'm pleased to introduce our speaker tonight, Dr. Brian Hitt. He is a board-certified UCI Health behavioral neurologist who specializes in the diagnosis and management of Alzheimer's disease and other cognitive and memory disorders. He earned his medical degree at Northwestern University Feinberg School of Medicine in Chicago, Illinois. He completed both the neurology residency and fellowship in cognitive and behavioral neurology at the University of Texas Southwestern Medical Center in Dallas, Texas. He holds a PhD in cell and molecular neuroscience from Northwestern University in Evanston. And he completed a postdoctoral fellowship studying tau protein seeding activity as a biomarker at the Center for Alzheimer's and Neurodegenerative Diseases at the University of Texas Southwestern Medical Center. When I met him tonight, I said, I can't believe that someone as young as you are has done all of this. He has just a remarkable, remarkable pedigree that he is coming to share with us tonight. He's going to be talking to us about what's new in the treatment and care of Alzheimer's. I suspect that probably each one of us has someone somewhere in our families who have been touched by this. I was thinking, when I was growing up, a child growing up, my relatives were forgetful, but they died early. They didn't live so long, and those of us now who continue on into our 80s and 90s find ourselves more and more susceptible. So it's wonderful to have Dr. Hitt with us tonight to share with us what's new. Please join me in welcoming him.
Thank you so much. So I'm a behavioral neurologist, which means I see patients with a number of different dementias and other neurological conditions affecting thinking and behavior. But tonight I'm really going to focus on Alzheimer's disease and talk a little bit about how we diagnose it and how that might be changing, how we treat it, and how that's also changing. And then I want to finish with some kind of practical things about what the science says about lifestyle factors that we know impact cognitive aging and can be protective against cognitive aging and also Alzheimer's disease specifically. So in diagnosing Alzheimer's disease, the first question we have to ask is this beyond what we expect for normal cognitive aging? Normal cognitive aging is a real thing. We expect certain things to change as we get older, particularly processing speed. Any cognitive processing speed, anything that requires cognition will take a little bit longer and a little bit more effort to do. So that normal cognitive aging affects some things but not others, mainly processing speed, actually starts declining in our mid-30s for most people, and is very, very slow and gradual. When we see something that is a little more pronounced and is a little bit more in the area of memory formation and retrieval is when we start worrying about something like Alzheimer's disease. Going back a little bit. So, as we notice memory changes, if it's beyond what's expected for normal cognitive aging, but it's not yet impacting our ability to perform our daily activities independently, that's what we call mild cognitive impairment. When it starts to impact our daily activities such that we need help from somebody else to do that, that's what we define dementia as. So there's a number of different causes of dementia, and as you can see by this graph from the Department of Health and Human Services, Alzheimer's disease is far and away the most common cause of dementia. So here this is focusing on the underlying brain changes that lead to the dementia. In the case of Alzheimer's disease, it's deposition of two different proteins, the amyloid beta protein that forms plaques in the brain and the tau protein that forms tangles in the brain. I won't say too much about those because I could talk for hours about them, so to keep it brief tonight, I'll kind of leave it at that. Other forms of dementia can be caused by other neurodegenerative conditions that also involve deposition of proteins, other proteins, such as frontotemporal dementia, dementia with Lewy bodies, or can be due to vascular cognitive impairment, which in most cases is due to slow and gradual changes to the smallest blood vessels in the brain as we get older, not letting as much blood flow through and causing damage to some parts of the brain. So the main risk factor, far and away the most important risk factor for Alzheimer's disease, is aging. It's very much a disease of aging, such that as we get older, the prevalence of Alzheimer's disease goes up dramatically, particularly between the ages of 75 and 90. It's very, very uncommon before the age of 65. What we typically see is that memory formation and retrieval is what's affected earliest, and throughout the disease tends to be the main thing that's affected. That, there are some atypical variants that have a different pattern than that, but that's kind of beyond what we have time to talk about tonight. As it progresses, it can affect things other than memory, and typically the progression is very slow. So we typically don't see big changes from year to year. This is something that progresses over about a decade or more in most cases. Also wanted to point out that women are affected slightly more than men for reasons that we don't fully understand. So while the changes of Alzheimer type dementia are noted primarily later on in life, we know from large series of autopsy cases that the changes that happen in the brain, those proteins that aggregate and deposit, happen much earlier than that. So this is kind of a schematic representing that. The first thing that happens is deposition of beta amyloid, which forms plaques. That's represented by this red line. About 10 years after that, on average, we'll start seeing deposition of the tau protein, which is represented by this blue line. That forms neurofibrillary tangles in the brain. Shortly after that, we start seeing shrinkage of the brain, what we call atrophy, so change in the size and shape of different brain structures, mainly affecting a structure called the hippocampus in the brain. And that's represented by this purple line. And then it's not until this green line that we start seeing symptoms, that we see our cognition affected. We start seeing that memory loss. And in the whole scheme of things, the beginning events, the deposition of beta amyloid, can start 20 years or more before we start noticing symptoms, or before it kind of comes to medical attention. As far as diagnosis, the only tried and true way to truly diagnose Alzheimer's disease is by actually looking for the plaques and tangles in slices of brain tissue under a microscope with autopsy tissue. So while somebody is alive, the best we can do, since they're still using their brain, is to make a clinical diagnosis. Say, how much does this clinical picture fit with what we typically see in people who end up being positive for the plaques and tangles? So to do that, the diagnostic workup typically involves 4 things mainly. You'll sit down with a neurologist or another provider and kind of give the history of what symptoms the patient and other people around them have noticed, and have a neurological examination done. We also get a structural MRI scan. So this is to look for those changes in the size of different brain structures that can often go along with Alzheimer's disease or other causes of neurodegeneration, and also to look for other alternative explanations for the symptoms that somebody is having. Most, but not all patients being investigated for possible Alzheimer's disease will have neuropsychological testing, which is kind of about 3 or 4 hours of paper and pencil memory testing to kind of look for the pattern of what is affected, what's not affected, what kinds of things do you have trouble with, what don't you. Does this pattern fit with Alzheimer's disease, or does it fit better with something else? And then oftentimes we'll check blood tests, looking at vitamin levels, thyroid hormone levels, and other things that could also explain this. So the basic workup that we do is mainly to confirm the pattern of what we get on the history and exam, but also to rule out other potential causes. Now, as new treatments become available, there's a kind of a push to focus more on a biological diagnosis, to actually diagnose Alzheimer's disease based on those pathological changes like the A beta and the tau deposition, because that's what the new generation of therapies are treating. And so we have some additional, what we call biomarkers tests that we sometimes use. The ones that are used in clinical practice now, the first one is an FDG PET scan, and this doesn't recognize the specific beta amyloid and tau changes. This just looks at the pattern of energy usage in the brain, and what this is most valuable at is distinguishing Alzheimer's disease from other types of neurodegenerative disease, like a frontotemporal dementia or dementia with Lewy bodies. It's not good at answering the question normal versus not normal. So this is used only, this is not something that we get routinely in the workup of potential Alzheimer's disease. The one true biomarker test that is currently approved and paid for by insurance and Medicare is CSF biomarkers, cerebrospinal biomarkers. So this requires a lumbar puncture to remove a sample of spinal fluid and look for two specific changes. The two things that happen over the course of Alzheimer's disease is that beta amyloid gets stuck in those plaques, so it doesn't get into the spinal fluid, so it goes down here on the y-axis, and a change to the tau protein called phosphorylation. And that does get into the spinal fluid, and so we see phosphorylated tau go up. So this is kind of a sample of the results that we get back from the lab, and when the results end up in this quadrant down here, that tells us that the changes of Alzheimer's disease are very likely to be happening in that individual. It's not a perfect test. It's not a yes-no test for Alzheimer's disease, but it does kind of help us in an individual that we already suspect might have Alzheimer's disease, push us one way or another to saying how likely we think it is. There's a couple tests that we use in research that are not yet used in clinical practice, but may be eventually. One is the amyloid PET scan. So this is one that uses a tracer that binds to beta amyloid in the tissue. There's 3 that are approved currently. There are a few pros and a few cons to using this. Again, not a perfect test, but it's been used in research enough that it does give us, we know pretty well how to interpret it, but it doesn't give us kind of a yes-no test. Some people will sometimes oversimplify it by saying that it shows the plaques in the brain. We cannot see the plaques. I'll just reiterate it again. The only way to see those is under a microscope with brain tissue. So this is an indirect way of saying how likely is there to be deposited beta amyloid protein in the tissue. We use this in research. We've been using it to select patients for clinical trials and to assess the activity of agents in clinical trials, but it is not yet used clinically. A couple of the reasons for that is it's very expensive and requires specialized facilities, and we have kind of a better way to do that with the spinal fluid biomarkers. We do have the first blood test now approved as an Alzheimer's disease biomarker, and this was approved last year. Took quite a bit of fanfare in the media, which I kind of want to put a bit of a damper on. This also is not a yes/no test for Alzheimer's disease. This is not a test you can get when you're young, and it will tell you whether you'll get Alzheimer's disease when you're old. This will not even kind of say if you're having memory loss, is it because of Alzheimer's disease? This is similar to the CSF, the spinal fluid biomarkers, but not nearly as accurate. It has the advantage, though, of being less invasive, as it just requires a blood draw. It depends on when you have this test done, because it takes age into account. And it uses a genotype of the ApoE gene, your age, and the ratio of two different versions of A beta in your blood to give you a probability score. And so you can see if your score comes back and it's right at 50, which is a score that you can definitely see, about, just as many people with or without beta amyloid by PET scan can get that score. So this is something that, again, in the right patient might help push us in one direction or another as far as saying this is likely or not likely to be Alzheimer's disease. This also is not currently used widely in clinical practice. That may change with the rollout of new therapies. As far as how we treat it now, as far as how we treat the cognitive symptoms of Alzheimer's disease, there are 4 medications that are approved for treatment. 3 of them are in the same class, so it's kind of one or the other. That's what we start with. They're called the cholinesterase inhibitors. Donepezil, which is Aricept, rivastigmine, which is Exelon, and galantamine is the third one. And these are medications that can help out with the cognitive symptoms. Most of the time they don't produce dramatic effects, but we do have good evidence from clinical trials that people taking these medications do a little better for a little longer in terms of their memory and functional independence than similar groups of people who are not taking them. So this is approved for mild to severe Alzheimer's disease. In the moderate to severe stages, we often add a medication called memantine. This works differently. It's a very well tolerated medication. Most people don't have any side effects from it. And similarly, not much of a dramatic effect, but we do have evidence that this combination of a cholinesterase inhibitor plus memantine does help people do a little better for a little longer. These are symptomatic treatments. Unfortunately, they don't affect the underlying cause of the disease. And that's kind of been the holy grail is, can we find something to actually slow down the progression of the disease? That's not something that these can do, but for the moment, this is still the standard of care in treating Alzheimer's disease. In addition, the other things that we do, day in, day out in a clinic like mine is manage other non-cognitive symptoms like mood and behavior symptoms and sleep disruption, which are very, very commonly associated with the memory symptoms of Alzheimer's disease. So we can use SSRI antidepressants or SNRIs for managing mood and behavior. For sleep, the safest thing tends to be melatonin supplementation. We can also use that for what we call sundowning, which is agitation, being really upset and confused in the evening. And we can also use, there's a couple different antidepressants that have sedating properties that we also use to help out with sleep, and that's mirtazapine and trazodone. Now, again, what we would really like to be doing is treating the underlying cause to slow down the actual progression of the disease. And so since we know that those changes happen early, we need to identify patients as early as possible if we want to do that, and that's why kind of clinical trials have been shifting to milder and milder symptoms, or even patients with no symptoms yet, and who they're targeting. But basically, the new treatments are trying to disrupt the deposition of amyloid or tau, and that's kind of the majority of medications that are currently in the pipeline. This is a really busy image here, but what I want to focus on is how this is kind of a representation of all the different treatments that are currently in clinical trials. And this has been the case for about the last 20 years. At any given time, there's about 130 different treatments in some phase of clinical trials for Alzheimer's disease. Most of them you'll see currently, is this going to work for me? There we go. Are kind of crowded into this green and purple area here. And these are the disease-modifying anti-amyloid or anti-tau treatments, that are the vast majority of treatments in clinical trials right now. The closer you get to the center, the farther along, so that phase 3 is there in the middle. The ones that have been have had all the buzz in the news are in this little slice right there. These are the monoclonal antibodies against beta amyloid, like aducanumab and lecanemab. Kind of one of the take-home messages of an image like this is about 130 treatments in clinical trials at any given time over at least the last 20 years. In the last 20 years, the last medication to be approved for the treatment of Alzheimer's disease was memantine 20 years ago. So in this time, we've been testing an awful lot of therapies. None have shown a clinical benefit. After memantine, the next treatment to be approved for Alzheimer's disease was aducanumab in 2021. That didn't get full approval. It got accelerated approval by the FDA. Did have significant risk to it in causing brain bleeding and brain swelling, and didn't show a clinical benefit and has essentially been abandoned. So although it got approval, it's not something that we think has any benefit for patients, and we're not using it. Now, lecanemab had an exciting clinical trial published in November of last year. This is kind of the key figure from that. It also had kind of similar risks to aducanumab. So any of these anti-amyloid monoclonal antibody infusions, these are not pills that you take, these are monthly IV infusions of antibodies to attack the beta amyloid, clear it from the brain. Anytime you're doing that, it turns out you can precipitate some swelling or bleeding in the brain, very small amounts of it, and for most people in these clinical trials, it was asymptomatic, but not for everybody. Some people did have pretty significant symptoms of it, though it was very rare. So did have some risk associated with it. But on the other hand, as opposed to aducanumab, there did appear to be a clinical benefit of lecanemab. And I kind of want to tell the good side and the bad side of this. So on one hand, this was an 18-month trial. The lecanemab group did separate from the placebo group in terms of how much decline there was over time. So again, just to kind of manage expectations, this is not a medication that can make you better. This is not a medication that can stop the decline. The best we are hoping for is to slow down the decline in function over time. And so this is, this represents a fairly small change in kind of your daily function. This is on an 18-point scale, and you can see that it's kind of a very small, absolute change that it represents. But I want to point out that this was just over 18 months of treatment, and this is the very first time that a treatment targeting A-beta or any other molecular change in Alzheimer's disease showed a separation of the treatment group from the placebo group in terms of how they were actually doing clinically. So this really was this a big breakthrough? Yes and no. I think it's not gonna dramatically change outcomes right away, but it does indicate a paradigm shift in the way we treat these diseases and gives us some hope that we can affect the trajectory of the disease. This is just the beginning of this type of therapy. So I want to shift gears a little bit and, kind of talking about the last 20, 30 years of research that has gone into this new generation of therapy. What we've really hoped for is to come up with some kind of treatment, some medication that we can give that addresses the actual underlying cause of Alzheimer's disease, that slows down the progression. And I think we're just barely getting there. But in the meantime, we've learned an awful lot about the disease and have found other things that are not medications that we've known for quite a while and have built up a pretty good body of evidence that they do affect the trajectory of the disease. And not just in people with a diagnosis of Alzheimer's disease, but general cognitive aging as well. And these are all lifestyle changes. So I want to spend the rest of my time tonight talking about, this is kind of what I focus a lot of counseling on in my clinics, the things that we know make a big difference in that. And I want to focus on the big four. There are a lot of different things that are kind of included in lifestyle factors, but the ones that we have the most and the best solid scientific research on are staying physically active, staying cognitively active, and especially socially active, cognitively active in social ways, sleep quality, and managing stress and anxiety. So we know from a tremendous body of evidence, many studies over many years now, that the regularity of physical activity is extremely important for cognitive aging. So the things that we find in the studies is that it doesn't really matter what the activity is. The main thing is how regular it is. So daily to at least 3 times a week have shown benefit in studies. The biggest difference in these studies has been between a sedentary lifestyle and any regular activity. Boosting it beyond that to really vigorous aerobic exercise shows a very minimal effect beyond that. It's that big difference between a sedentary lifestyle and regular physical activity. A number of different things have been studied, a number of different types, from walking, cycling, swimming, balance, things like Tai Chi or Qigong have all been studied, and they show very similar results. It is what you stick with, what you enjoy, what you find engaging and will do for its own sake, and will do it regularly. Those are the things that show a benefit for people's cognition over time. We have evidence not just from those epidemiology studies studying what people do and how well they do, but also for intervention trials, taking groups of people and randomizing them and having one group kind of be more physically active and kind of giving them the tools to do that does show a difference. We know that this is not just kind of a non-specific effect. This really does affect the physiology of the brain as well. And we know that from animal studies where, kind of on the most basic level, if you take animals that are kind of genetically designed to get Alzheimer's disease and you give some of them running wheels and some of them none, the ones with the running wheels have, amyloid deposition and Alzheimer's disease pathology in their brain that progresses more slowly. So this is a real physiological effect on the brain. So like I said, as far as cognitive activity, the studies that have shown the biggest benefit are ones that look at staying socially active. So social isolation is one of the biggest risk factors for a faster decline. We have kind of some of the landmark papers in the field of lifestyle factors have been ones that show the effect of isolation. So the last several years with the COVID pandemic have really kind of negatively affected patients with cognitive aging and with Alzheimer's disease in a tremendously negative way. Let's see, did that. And so, the things that have shown a benefit in this area is the regularity of interacting with kind of a number of different family members and friends. People that belong to groups do better than people who don't belong to groups. And the complexity of your social support network also predicts how well you do over time as well. A number of different activities have been looked at. Reading, keeping up with hobbies, learning new things. Novelty tends to be a really common element in the things that show a good effect size. So learning a language, learning a musical instrument. So novelty is very important. The other thing that seems to be important in all these studies, they ask people how engaging they found the activity, how much they were motivated to do it for its own sake, and so that you're not doing it just as a sacrifice. That seems to be, one of the very strong predictors of how much benefit people get from it. So finding things that are engaging and that are enjoyable to the individual and things that involve some kind of novelty, learning new skills, learning new information is the big one. Interestingly, some of the really great and exciting studies in this area with, impressive effect sizes in the last 5 years have been in the area of music. So there are a couple big studies from USC a few years ago that followed sibling pairs that had learned a musical instrument in childhood and followed how frequently they played music in adulthood, and correlated very well with cognitive aging. Learning new music, learning new musical instruments, and also learning how to sight read in adulthood, similar to the language learning studies that were done about 5 years ago, was shown to provide a really good cognitive benefit. So again, with that novelty effect. So sleep quality is something that, I think everybody recognizes the short-term benefits of getting a good quality sleep. When you don't sleep well at night the next day, you have difficulty with attention and concentration. Mood can suffer as well, but we know from studies in the last 5 to 10 years that there are long-term effects of inadequate deep sleep on the brain. Actually increases the amount of neuroinflammation, can actually accelerate the process of neurodegeneration in people who are prone to Alzheimer's disease or have those molecular changes starting. And the key thing is deep sleep. So kind of going through those normal sleep stages, sleep cycles, and getting adequate deep sleep is kind of what seems to be the most important thing. Kind of a couple big things to point out. Obstructive sleep apnea, this is something in our neurology clinics we try to never miss. Everything in neurology gets worse when there is untreated obstructive sleep apnea. Sleep apnea is kind of custom designed to not let you get into deep sleep. As soon as you do, you're not breathing adequately and you wake yourself up, and so that type of sleep that we know is necessary for the brain, is what suffers there. This is very treatable, and it's a very, very common reversible cause of cognitive impairment. In addition to sleep apnea, there's kind of run-of-the-mill insomnia that now we know is kind of it's not just annoying, it's very important to address and to treat so that you get adequate sleep in the long run. So sleep hygiene is the main thing that we focus on, and the key elements of sleep hygiene have to do with what you do in the 2 hours before bedtime. You should have a consistent bedtime, and in that 2 hours before bedtime, the sleep specialists will always recommend that you start dimming the lights, avoiding stimulating activities, avoid screens in particular, screens that are close to your face, so like laptop screens, smartphone screens, especially tablet screens. Those tend to be blue shifted, so blue light that tells your brain it's daytime, is kind of enriched in those tablet screens. and doing activities that promote relaxation in those 2 hours as well. If you're not able to fall asleep when lying in bed, after 15 to 20 minutes, it's best to get up, get out of the bedroom so that your brain doesn't associate lying awake with being in your bed. So short of prescription sleep aids, melatonin can help out a lot. This is kind of a safe thing to do to improve sleep quality. It's not a drug, doesn't make you drowsy, doesn't knock you out. It's something that's a natural signaling molecule in our brain that tells our brain when it's nighttime, when it's time to be asleep, and starts to rise about an hour before we naturally fall asleep. So that's the best time to take it, to kind of accentuate that big spike that happens in the beginning of the night. This can help quite a bit. Similar to sleep quality, stress and anxiety is something that we know in the short term affects our attention, concentration, but we now know that long-term high circulating levels of stress hormone levels can pose a risk to cognitive aging and to brain health in general. In the case of anxiety and anxiety disorders, kind of high levels of anxiety over the long term, talk therapy can help quite a bit. Non-medication therapies to try to reduce that stress level, but in some cases, medications can be necessary to kind of manage that anxiety level as well. So that is definitely something that if you find yourself suffering from, over the long term, talking to your physician about ways to manage that is really important. Managing stress and anxiety, some lifestyle interventions. This is kind of trial and error. Different people find different things helpful as far as kind of breathing exercises, relaxation exercises, mindfulness practice and meditations. This is kind of easier than it's ever been because there's now things like smartphone apps that can kind of walk you through, practices like relaxation exercises and meditations and things like that. I mentioned a couple that have kind of robust free versions here. You'll notice that in the big four, one of those is not diet. Been studied extensively over the years, and if there was kind of a major effect size to find, it would have been found 100 times over. Seems like whether or not you get dementia has very little to do with what you eat or what you don't eat. So the key thing I would say is to choose your diet for cardiovascular health, not for brain health. We find that when we do find little benefits for brain health, it's always the heart-healthy diets that tend to be the best. So things like the Mediterranean diet, the American Heart Association's DASH diet, these are all things with, very common elements, things like a lot of fresh fruits and vegetables, lean sources of protein, low fat, low saturated fat in particular. And then just to kind of wrap that part up, this slide can save you a little bit of money. A lot of people won't want me saying this, but no dietary supplement has been shown to have benefit for cognition. In particular, if anything is expensive and making claims to either protect you to prevent dementia or to improve any part of brain function, it's a scam. It's a money-making endeavor and not based on science. The things that are safe and reasonable to kind of prevent deficiencies are things like vitamin D3, vitamin B12, omega-3 fatty acids, as long as you don't have a bleeding disorder, and curcumin, which is kind of the active ingredient in turmeric. I put my kind of general rule of thumb here for supplements. They're okay if there's no potential for harm, if they're not expensive, and if you feel better taking it than not taking it. As far as no potential for harm, I would say anything that doesn't tell you on the label exactly what's in it and what amounts are in there. Anytime you see the phrase proprietary blend, we cannot guarantee that it does not contain something that is harmful. So I would generally recommend staying away from things like Prevagen and other proprietary blends of dietary supplements. I'll just wrap up with our UCI Memory Clinic. I have clinic in 3 different locations, in Irvine, in Laguna Hills, and in Orange. For all 3, this is the phone number for that. And I think we'll take questions.
Great. Can you hear me? Good. Thank you, Dr. Hitt. Can we thank him, and then I will go into the audience and... All right, I will be coming around with the microphone so you can ask your questions. I see we have tons of questions, so start here.
Is it safe to take melatonin every day? And if so, do you have to up the dosage for it to still be effective?
So it is safe. The one caveat is when you're coming off of it, if you need to stop it for any reason, it is best to come off of it slowly, especially if you're, so a lot of people prefer to stay at really low doses. If you're taking something like 1 or 3 milligrams, that's something that's usually safe to just stop it. If you're taking 10 milligrams daily, probably want to drop that down to 5, then 3, then 1, and then stop it.
What's the difference between what we were talking about and what I'm feeling?
The memetine.
No,
go ahead.
no. It starts with a D.
Dementia.
Dementia.
And what?
Yeah. So dementia is the word that we use to say that you're having difficulty taking care of your daily activities. So things like getting dressed, bathing, grooming, and eating meals, or even things like kind of managing your schedule, managing your medications, and need help from somebody else to do that. And it's because of memory problems and not orthopedic issues or injuries or things like that. When your cognitive changes are causing you to need help from somebody else to do your daily activities, that defines dementia. It doesn't tell you what's causing it, though. So that's not, kind of a disease process. It's just a descriptor. And Alzheimer's disease is far and away the most common cause of dementia.
Is there any hereditary aspect to Alzheimer's?
Absolutely, great question. So the vast majority of Alzheimer's disease, upwards of 99%, is what we call sporadic Alzheimer's disease, which means it's not due to a gene mutation. It's due to a complex mix of different risk factors. You can kind of picture a big pot that a lot of different things go into. A lot of those are genetics, but not gene mutations. These are just the same kinds of gene changes that make us all look different, kind of makes our brains work differently as well, and make some people more prone to Alzheimer's disease than others. What we know is that if you have a first-degree relative, so that's a parent or a sibling that's affected by Alzheimer's disease, it increases your risk slightly above that of the general population. But it is not at all deterministic. There are plenty of people that have 2 parents affected, have no Alzheimer's disease in the children. There are plenty of people who get Alzheimer's disease that don't have anybody in their family affected. So not deterministic at all, just a probability thing. There is, 1 to 2% of cases of Alzheimer's disease that are kind of very early onset cases that are what we call familial Alzheimer's disease. And these are people who get Alzheimer's disease in their 50s or even their 40s, and it's because of a gene mutation that causes Alzheimer's disease. These families generally know who they are, and it's fairly rare.
Hi, thanks for being here tonight. I think I understood that there hasn't really been any success or much success at all in finding drugs that help treat or prevent dementia. If someone has advanced memory problems, can their memory be improved by anything? And if they haven't been identified as what type of dementia they have, but they clearly have a lot of memory loss, still recognizing people and functioning to some degree, is it worth looking into, like, okay, that was Alzheimer's or that was vascular this or?
So that's a great question. Kind of the the short answer to that is, regardless of what we think the cause is, management of it is the same. We focus on the things that affect quality of life. So we treat, even non-Alzheimer disease causes of dementia, we treat with the same medications, kind of different levels of evidence for how much impact they can have. But we recommend the same lifestyle interventions. We recommend the same medications for the cognitive symptoms, and we end up oftentimes managing very similar non-cognitive symptoms as well. Mood, anxiety, sleep, agitation, things like that are things that can really impact quality of life, and that we can. Right. These all tend to have in common, they only go in one direction, unfortunately. They get worse over time. The exceptions are if we find a cause like a dietary insufficiency or obstructive sleep apnea or something that is the cause that is treatable, that can get better.
My understanding is that there's some development happening in regards to delivery of medication by going through the nasal passages, that increases the likelihood of medications crossing the blood-brain barrier. Do you know anything about that? Can you explain any of that?
So, kind of like the slide that shows the kind of 130 plus treatments that are in therapy, there have been a number of treatments delivered intranasally that have gone into clinical trials. Nothing has been shown to be effective, and there's really nothing at the moment that is in late stage clinical trials that's showing promise that is intranasally delivered. So kind of a great thought that, kind of a lot of effort was put into kind of testing intranasal delivery of certain things. But, to this point, no evidence for its benefit.
Hi there. I've read studies that both say estrogen therapy is helpful postmenopausal and then estrogen therapy is harmful for cognitive health.
So this is one of the big roller coasters in our field, and it's a long one. This started in the 1990s. With research that suggested, actually kind of stemming from the observation that women tend to get even adjusted for the fact that, women live longer than men, women tend to get Alzheimer's disease at every given age a little higher rate than men do. Why might that be? And, the hormone changes associated with menopause were implicated. And the initial evidence suggested that maybe hormone replacement therapy could be very helpful in this. It was extensively studied, and then the pendulum swung way far in the other direction. And it was like, wait a second, this might not only be not helping cognition, but might be increasing levels of cancer. And so backtracked a whole bunch and said, no, nobody should get it now. It's kind of right in the middle. It's, don't get it for the purpose of, protecting against dementia. Don't completely avoid it for the purposes of cancer, but take it on an individual, person-by-person basis and talk to your doctor about it.
We have a lot of information about the disease. What is your best advice for the caregivers?
So That's a fantastic, that's a really, really important element of care. There are a lot of really great community organizations. Here in Orange County, we have one of the best in the country, and that's Alzheimer's Orange County. And so I would direct anybody to alzoc.org. They're a fantastic kind of clearinghouse of information and resources for caregivers. They, have kind of, there's also the local chapters of Alzheimer's Association, which kind of does a number of functions, but Alzheimer's Orange County has really made it their mission to focus on community resources and caregiver support. And they have a number of different caregiver support groups, that kind of focus on, different challenges that different groups of caregivers are facing at different stages of the disease. There are a number of books that have been written to kind of help with caregivers as well. One that the social workers and speech therapists, very frequently mention to me as a high quality one is the 36-hour day, geared specifically towards caregivers of patients with dementia. And so finding support from people who have dealt with, kind of similar challenges can be really helpful, just to feel less alone, and to kind of share in the problem solving.
I'm part of the UCI Mind Alzheimer's study, currently on infusion for the last 9 months. Can you tell me a little bit more about this study, or us actually a little bit more about the study?
So UCI Mind is, kind of a large clinical research group at UCI that encompasses a number of different, goals. One is the longitudinal observational study through UCI Mind, which doesn't involve any particular treatment, just follows people over time, gathers kind of information about what the progression of normal cognitive aging and also Alzheimer's disease looks like. And then they also have a number of NIH-funded clinical trials that go through UCI Mind as kind of a central place for recruitment and kind of following patients. So I'm not sure exactly, what specifically that trial is, but that would be kind of one of the clinical trials that's ongoing for, one of the many potential treatments for Alzheimer's disease. If it's an infusion, it's likely kind of one of those anti-A beta monoclonal antibody treatments.
Hello. Thanks for your time today. If we have a parent that's been diagnosed with mild cognitive impairment, but not necessarily dementia or Alzheimer's, did I hear you say that the treatment would be the same? So at what stage or how important, or why would one want to go to further diagnosis to see if there is Alzheimer's there or anything else, or just really focus on the lifestyle factors, which seems to be what we've been doing, and may not have agreement on doing further diagnosis with the doctors?
Yeah, absolutely. So the main purpose for kind of coming to a more specific diagnosis is usually so we can help give you the best information we can as far as what to expect and what challenges you may face in the future, what the time course might be like, because that does vary, depending on the cause of mild cognitive impairment and of dementia. It's important to note that not all mild cognitive impairment does progress to dementia. There are certain causes of mild cognitive impairment that stay stable or that even improve over time and go back to normal cognition. One of the ones that the one we don't want to miss is sleep disorder associated cognitive impairment. Obstructive sleep apnea is 100% treatable, and oftentimes in those cases, patients' cognition really does go completely back to baseline. So it's not a sure thing that that it will progress. But what we find, particularly in patients where Memory is the main thing affected, what we call amnestic mild cognitive impairment, or amnestic MCI. When we follow those patients over time, it generally tends to be a precursor of Alzheimer type dementia. And, following them over time, depending on what study you look at, every year about 10 to 15% of patients with amnestic mild cognitive impairment do cross over that line, start needing help with daily activities, and qualify for a diagnosis of Alzheimer type dementia.
Possible for you to put the slide back up of the social slide? I wanted to get a picture of that.
There. Is that it?
Yeah, thank you.
Okay.
My question is about sleep. If you don't get a regular 8 hours every night, is there value in a power nap?
So napping is something that comes up frequently in my clinic. Naps can be perfectly healthy. Most healthy naps are less than an hour long. When you feel the need to sleep more than an hour during the daytime, that can sometimes be, an indication of an increased sleep need as you get older, which is not unusual, but it can sometimes also indicate that your sleep quality at night is inadequate and, maybe worth kind of focusing on kind of sleep hygiene things to see if that, that need in the daytime goes away.
Is there anything in study relative to ethnicity?
Absolutely. So that is, that is a huge issue in clinical research and in clinical trials in particular. Kind of all areas of medicine and neurology, and in particular our field, has had a lot of difficulty recruiting representative samples of patients for clinical research with respect to ethnicity in particular. And so, a lot of what we know about dementia is, kind of mainly reflects dementia in kind of wealthier white populations. We know that in some non-white populations, the incidence of Alzheimer's disease is actually higher. And there's some indication from some recent clinical trials that target A-beta that the effectiveness of those types of therapy might vary by stage of the disease, ethnicity, and especially sex. We found in the lecanemab trial that men had a tremendous benefit from lecanemab versus placebo, but the women in the study did not show a statistically significant difference above placebo. The bars crossed each other. So they did show a little bit of a trend towards benefit, but not nearly as much benefit as men got. So this is an important area of research, and we're really hoping to find ways to kind of increase the representativeness of the samples we get for clinical trials.
There a long-term vulnerability, a greater risk for Alzheimer's from using prednisone, prescribed prednisone for lung disease for a number of years?
So long-term use of prednisone, it has a very, very long list of potential downsides and side effects. And it does put you at risk for a number of things, particularly orthopedic issues and skin conditions and things like that. Neurology is kind of a bright side of that, where, it's not really a major risk factor for developing neurological disease. We use a lot of steroids to treat neurological diseases. So it seems like less inflammation is better for the central nervous system.
My question is about taking the nementine and galantamine. Is there a benefit after taking it for a while? Does it, I know it's supposed to slow the progression of the disease, but if your patient or your loved one has been taking it for a while and you just see the progression go on and on, is there a benefit to keep on taking those after years?
Yeah, so I usually kind of draw this out in the clinic of kind of a graph of the effect of those types of medications. First, I'll just say that it doesn't slow the underlying progression of the disease. It's a symptomatic treatment, but it does kind of symptomatically help patients do a little better for a little longer. And that's something where in the clinical trials, that effect of kind of stabilization lasted for, a certain amount of time, and then basically the trajectory of the disease caught up with the control group, essentially. And so that has led to the question, is there a benefit to continuing the therapy? It's a very reasonable thing to ask. We usually give the patient the benefit of the doubt and figure, maybe you are getting some kind of benefit from it. Sometimes, especially if patients have any kind of a hint of a side effect of it, I have very low thresholds for stopping it. Most often what I'll do is, start with one at a time. Let's go ahead and stop the memantine, see how you do for a couple weeks, and then decide, did you feel better on it or off of it? And make the decision that way.
First, wanted to thank you for sharing your knowledge with us this evening. Very informative. This question circles back to the discussion on sleep quality. And, right now there are a plethora of devices that we can buy at the local electronics store to wear and give us some indication of what our sleep was in the prior evening. And I'm wondering if the medical community has high regard or any regard for these type of devices in trying to assess whether I'm getting a good sleep or not.
Great question.
Thank you.
So in a sleep study done in a neurology, kind of neurology sleep clinic lab, the kind of gold standard for sleep stages and kind of whether you're going through the proper sleep cycles is EEG. That's very cumbersome. Not an easy thing to do. But when they do studies of how well, kind of the devices that are available to the consumer are actigraphy devices, so basically measurements of movement, sometimes combined with, things like heart rate and other kind of measures. There's some overlap with EEG, but not perfect. The ones that I've seen patients in my clinic kind of bring me the reports of seem to be pretty sophisticated, and the ones that the kind of recent ones that have been compared to EEG do pretty well. So I think that it is a pretty good indicator of your sleep quality overall.
All right. One more question. Is there one more? Jerry, maybe.
So if someone can't easily go get a scan of the brain, but they do think they have the potential for Alzheimer's, where is the best testing to go for the neurological testing or something that can help them?
So in somebody who does not yet have a diagnosis, just a suspicion, kind of subjective cognitive changes,
yes.
I think having an evaluation by a neurologist is the best place to start. There's no one diagnostic test that is universally, helpful to diagnose this. The thing we start with is the history, a neurological exam, and kind of going from there, deciding if an MRI would be helpful, deciding if any of those other kind of biomarkers or otherwise studies would be helpful.
There's nothing that, these things that they put online and say this is going to help you determine. So none of those are good.
I'm not sure what those would be.
They're like some tests that bunch of questions they ask you, and they say.
Oh, so like a cognitive screening evaluation.
Yes.
So there are a number of those that are used in primary care offices and also neurology offices like mine. The ones you'll see are the MMSE or the MOCA, or sometimes the Kochman. And these are all basically 5 to 10 minute screening exams. Most of those require that somebody who's been trained in administering them, administer them. The score, personally, I find to not be as useful as actually sitting with somebody and seeing how they do it. What's valuable to me is seeing what the pattern is, what kinds of things they have trouble with, what kinds of things are easy for them, and what they struggle with. That kind of helps point the direction of what pattern am I looking at. There's one that is something that you self-administer, and I'm trying to think of. It's from Ohio State University. So if you look on the Ohio State University Neurology website for a self-administered cognitive exam, they have a really, really well characterized one.
Oh, great. Thank you.
All right, well, thank you, Dr. Hitt. This has been very helpful to all of us. We appreciate your coming, sharing your expertise. The video of this presentation tonight will be available on our website. Our events are available on our website. On February 27th, Dr. Dawn Lombardo will be here talking about, is my heart healthy? So we hope to see you back, and thank you for coming.